Good morning, ladies and gentlemen. I would like to thank the organizers for enabling me to present you an update of the Polish guidelines that were established at the end of this year, at the end of November. But I want to start with this slide. So in recent years, depressing data have been published suggesting no benefits of vitamin D supplementation on bone metabolism, on the risk of falls, on the risk of fracture, or even on bone density, or no effects of vitamin D supplementation on the risk of cardiovascular disease, cancer, or type 2 diabetes. As you see, papers have been published in Journal of American Medical Association, the British Medical Journal, Lancet Diabetes Endocrinology, or even in the New England Journal of Medicine. A good example is the VITAL study, in which the effect of the supply with the use of 2,000 units per day for about 5 years was investigated. And this study found no benefits in terms of decreasing the risk of developing cancer. But when the data from the VITAL study was reanalyzed, was investigated again, it was found that patients enrolled in the study were properly supplied with vitamin D. The 25-OHD at baseline was 30 nanograms per ml, and they supply in 2,000 units per day had still a very positive effect on the risk of cancer development. In other words, it reduced the risk by as much as 25%, or as long as one per 4 of people supplemented with vitamin D compared to placebo group avoided cancer when the first years of this data were omitted in the analysis. So such controversy that caused was a major cause or cost that to look at our recommendation and their updates. So I am very pleased to present you the newest developing this year, yet unpublished but accepted by the group of authors from Poland, recommendations for the prevention and treatment of vitamin D deficiency. Among the authors, you will find presidents of Polish scientific medical societies, national consultants, for example, president of the Polish Society of Public Health, the president of the Polish Society of Endocrinology, and many others. So let's start with the outline of general recommendations. So prevention and treatment of vitamin D deficiency in Poland is based on the use of cholecalciferol, or in certain diseases, calcipediol, and this is the new idea. Cholecalciferol should be considered as the drug of the first choice, both in prophylactic and therapeutic options. Calcipediol, however, should be used as the second-line drug when the use of cholecalciferol did not improve 25-OHD levels, or an immediate increase in 25-OHD levels is required, or the patient suffers from the liver disease associated with decreased hydroxylation at position 25, or malabsorption syndrome, or suffers from obesity. Prevention of vitamin D deficiency in the general population, in the general healthy population with the use of cholecalciferol, should be individualized depending on the age and body weight. If disease-specific guidelines are not available, such as guidelines, for example, for osteoporosis, prophylactic treatment of vitamin D deficiency with cholecalciferol should be instituted in the group risk vitamin D deficiency is agreed for general population. The maximum available doses of cholecalciferol for a given age group in the general population are recommended for use in the group at risk of vitamin D deficiency. What are the principles of cholecalciferol and calcifediol treatment based on results that you are most likely will see or you saw in your general practice? I mean the 25 OHG levels below 20 nanograms per ml. So if you have a result showing that the 25 OHD value is lower than 20 nanograms per ml, so this reflects the urgent need to start the treatment, not the prophylactic but only the treatment. Dosage of cholecalciferol and calcifediol in the treatment of vitamin D deficiency should be based on serum 25 OHG concentration and previous prophylactic regimens. Treatment of vitamin D deficiency should be continued for 1 to 3 months or until 25 OHD concentration will be close to optimal values, 30 to 50 nanograms per ml. And this must be followed by the maintained dose. In Poland, it is not recommended to use a single loading dose with cholecalciferol. I mean the doses higher than 100,000 units. And the most important are the two next points. That the first one, daily and cumulative weekly or monthly dosing regimens of cholecalciferol therapy are complementary in terms of improvement of 25 OHG concentration and safety. So I mean that 1,000 units given daily is equal to 7,000 units given once per week, or even to 30,000 units given once per month. However, caution is advised when using cholecalciferol outside the summary of product characteristics. And the second point, the daily dosing regimens, including oral solution with use of calcifediol in the dose of 10 micrograms, or as weekly as as well as biweekly with the use of soft capsules, and monthly dosing soft capsules with calcifediol are safe, but this dosing is not equal in increasing 25 OHD concentration. Therefore, again, caution is advised on using calcifediol outside the summary of product characteristics. And what are the recommendations for general population without 25 OHD levels assessed previously? So in healthy adults, cholecalciferol as the first choice of supplementation and calcifediol as the second choice should be both implemented in the prevention shape. Supplementation based on cholecalciferol in daily doses of 1,000 to 2,000 units is recommended based on body weight and dietary vitamin D intake throughout the whole year. If above supplementation guidelines are not fulfilled, alternative prevention based on calcifediol is in a daily dose of 10 micrograms in oral solution is recommended throughout the whole year. For a little bit older people, in seniors, cholecalciferol as the first choice of supplementation and calcifediol as the second choice should be both implemented in the prevention shape. The doses, the daily doses of cholecalciferol is 1,000 to 2,000 units daily throughout the whole year. And calcifediol in a daily dose of 10 micrograms as an alternative prevention is recommended throughout the whole year if above guidelines are not fulfilled. And the older seniors and the oldest olds In these groups, cholecalciferol, as I told you, is the first choice of supplementation, and calciferol is the second choice. But there's a difference due to decreased efficacy of the skin synthesis, potential malabsorption, and altered metabolism of vitamin D. Supplementation of 2,000 to 4,000 units daily based on body weight and the dietary vitamin D intake is recommended throughout the year. Calciferol, again in a dose of 10 micrograms, is as the alternative prevention is recommended throughout the whole year if above guidelines are not fulfilled. So here are the cholecalciferol therapy data. So saying again, 4,000 units per day, or even 7,000 units per day, or 10,000 units given per week, or 20,000 units taken biweekly, or 30,000 units taken biweekly, or 30,000 units taken once per month are recommended for the therapy of vitamin D deficiency. 25 OHG concentration control assay considered should be considered 8 to 12 weeks after the first intake, but not later than up to 3 months after the first intake, depending on the dose of therapy. And calciferol therapy, calciferol in a dose of 10 micrograms daily, or 266 micrograms taken biweekly or monthly is recommended for the treatment of vitamin D deficiency. And the first 25 OHG concentration control assay should be performed not later than 6 to 8 days after prevention with the use of 10 micrograms, and 4 to 6 weeks after therapy, or with the use of 266 micrograms using soft capsules. I would like to say some words of summary, but I can only say Sława Ukrainie, Herojom Sława. Thank you for your attention.